Good morning. My name is Ashwin. Today, I and my friends are going to present about pacemakers and the cardiac conduction system. First of all, these are the table of contents which we are going to present today that consists of introduction, functionality and suitability, current limitations and improvements, and conclusion. So I'm going to start with the introduction about cardiac conduction system. Our heart has its own electrical conduction system that controls how it beats. Normally, the electrical impulse starts at SA node, which acts as pacemaker of the heart. So, this impulse spreads across the atria, causing them to contract and push blood into the ventricles. And then the signal reaches the atrioventricular node, or we call it AV node, where there is a short delay. This delay is very important because it allows the ventricles enough time to fill with blood. After that, the impulse travels through his Purkinje system, causing both ventricles to contract together. So this coordinated process ensures efficient pumping of blood to the lungs and the rest of the body. So next is a simple introduction to pacemakers. What is pacemakers? Pacemakers are small implantable medical devices used to treat abnormal heart rhythms. They are commonly used in patients whose hearts beat too slowly or whose electrical conduction system does not function properly. Pacemakers work by delivering controlled electrical impulses to the heart when the natural conduction system fails. So the device consists of a pulse generator and leads that deliver these impulses directly to the heart muscle. You can refer to the diagram. Modern pacemakers are programmable and can adjust the heart rate based on the patient's activity, helping to maintain a stable and appropriate heart rhythm. I also attach a diagram of types of pacemakers, which are dual chamber, single chamber, and leadless. Next, what is the connection between cardiac conduction system and pacemakers? Okay. When the cardiac conduction system is disrupted, serious rhythm disorders can occur. One of the most severe conduction is third degree AV block, also known as complete heart block. So, in this condition, electrical impulses from atria do not reach the ventricles at all. So, this causes the atria and ventricle to beat independently. As a result, the ventricles rely on a slow and unreliable escape rhythm, which can lead to dizziness, fainting, heart failure, or even sudden death. So, the main treatment for symptomatic complete EV block is permanent cardiac pacing. So, dual chamber pacemakers are especially important because they stimulate both atria and ventricles in sequence. This helps to restoring atrioventricular synchrony and closely mimicking normal heart rhythm.
Greetings to everyone. I am Liu Tong from Group 1. Today, I would like to talk about the functionality and suitability of dual-chamber pacemakers. Pacemakers are medical devices engineered to regulate abnormal cardiac rhythms by delivering electrical impulses to the heart. Among other cardiac disorders, they are primarily utilized to treat bradycardia caused by sinus node dysfunction or atrioventricular block. Pacemakers may be temporary or permanent, contingent upon the patient's specific requirements and technological advancement. A dual-chamber leadless pacemaker system comprises two percutaneously implanted devices, one in the right atrium and the other in the right ventricle. Leadless dual-chamber systems such as Abbott's Avia-DR employ implant-to-implant communication using conductive signals through blood and myocardium for beat-to-beat AV synchrony without transvenous states. The system delivers electrical impulses directly to the heart muscle to restore the normal heart rhythm. The diagram shown here is the structure of the pacemaker. Each pacemaker is a fully self-contained unit with a fixed helix design, delivered percutaneously via a catheter through the femoral vein to the intended cardiac chamber. Next is the relation of dual-chamber pacemakers to anatomy and physiology. Atrioventricular block is a cardiac conduction system disorder caused by impaired transmission of electrical impulses from the atria to the ventricles. It is classified into three types. Today, we are focusing on the third-degree atrioventricular block. Third-degree atrioventricular block is characterized by a complete absence of electrical conduction between the atria and the ventricles. The SA node cannot act to control the heart rate without appropriate conduction through the AV node. If this left untreated, the condition can be life-threatening. Most affected patients require implantation of a permanent pacemaker, while temporary pacing may be used in selected cases as a bridging measure until permanent pacing is established. So, how does a pacemaker function? A third-degree AV block results in total heart block when no P waves are produced to form QRS complexes, and this causes AV dissociation, which is the absence of electrical communication between the atria and ventricles, results in no relationship between P waves and QRS complexes. Here, the pacemaker does its work. An escape rhythm from a ventricular or junctional pacemaker sustains cardiac function. Escape rhythms that originate above the His-Mandel bifurcation usually produce narrow QRS complexes, consistent rapid heart rates, and moderate symptoms such as fatigue. There are 4 different types of blanking periods in DDDR pacing modes. Every time the atrium paces or detects, a non-programmable atrial blanking period is initiated, usually lasting 50 to 100 milliseconds. The atrial light cannot detect its own pacing stimulation or the corresponding P wave during this time. Moreover, a ventricular pace or sense event, usually set at about 220 milliseconds, initiates the post-ventricular atrial blanking period. The purpose of this device is to stop the atrial lead from detecting far-field ventricular signals like the intrinsic R wave or ventricular pacing output. In dual-chamber pacing, each ventricular pace or sense event is followed by a non-programmable ventricular blanking time to prevent improper detection of the intrinsic R wave or ventricular pacing pulse. This period lasts 50 to 100 milliseconds and is dynamically adjusted based on signal strength. Additionally, a ventricular blanking period occurs after an atrial pacing pulse to prevent sensing of the far-field atrial stimulus.
Next, let's look at why normal heart coordination is so important and what happens when it is lost. In a healthy heart, the atria contract first and followed by the ventricles. This timing allows the ventricles to fill properly before pumping the blood out. A proper atrioventricular timing is essential for adequate cardiac output, meaning enough blood and oxygen is delivered to the body. However, not all the pacemakers preserve these natural coordinations. Many single-chamber pacemakers are designed mainly to correct the heart rate, but they do not restore the normal timing between the atria and the ventricles. When AV synchrony is lost, the heart becomes mechanically inefficient. Even though it is beating, it is not pumping optimally. Not only that, electrical pacing without coordination does not replicate natural cardiac conduction. Besides that, there are patient populations with greater needs, such as patients with atrioventricular block, patients with sick-center syndrome, individuals with impaired ventricular functions, and elderly patients who are more sensitive to reduced cardiac efficiency. For these patients, simply maintaining a heart rate is not enough. Thus, they need pacing strategies that restore physiological AV synchrony so the heart beats in a more natural way. Not only that, they also need devices that support both electrical rhythm and mechanical efficiency to ensure effective pumping. In addition, long-term monitoring of both atrial and ventricular activity is important for adjusting therapy. Most importantly, therapies should align with the heart's anatomy and physiology, rather than just forcing a rhythm. Therefore, these medical needs explain why more advanced pacing technologies are necessary. which leads into the next part of our presentation. Now, let's look at the innovation impact of the modern pacemakers. By maintaining AV synchrony, we significantly reduce long-term complications, specifically lowering the risk of pacing-induced cardiomyopathy and the progression of heart failure. Besides that, it also improves the quality of life and symptoms relief. It improves exercise tolerance and enhances quality of life in patients with atrioventricular block and sick sinus syndrome. It allows patients to return to their active daily routine with confidence. Moreover, innovations also brings intelligence. This device provides continuous monitoring of both atrial and ventricular activity. This enables early detections of atrial fibrillations, conduction delays, and cardiac pauses. Lastly, it also improves the physiological replications of normal cardiac functions. It coordinated pacing of the right atriums and the ventricular, so we ensure that atrial contractions always precedes ventricular contractions. This optimizes ventricular filling, stroke volume, and total cardiac output, which effectively mimicking the heart's natural and health performance.
So now let's talk a bit about the limitations and improvement. First, the limitations. The most common limitation about pacemaker is its very limited battery lifetime that can go to the worst case scenario of 3.5 years and to the best case scenario of only 35 years. So some of you might be wondering, why not we just replace it when the battery is depleted? However, this is very hard due to the surgery process that is very difficult and costly. So scientists have proposed some idea in order to solve this. Some of them are wireless charging, which is cannot be able to be applied due to the fact that the pacemaker is in the mediastinum, which is very flooded by blood that can interfere with the signal transfer. Next, some also proposed the idea of electromagnetic technology, which is very practical due to the nature of magnets, which is first very heavy, and second can interrupt with the process of MRI in the future cases that the patient will be needing it. And some also propose using piezoelectric technology. However, this also cannot be applied due to it not being able to supply enough voltage. And the same goes for the subcutaneous solar panel, which is also the same that it cannot supply enough voltage. Fortunately, some researchers have managed to come up with a pretty effective solution by focusing on harvesting the biomechanical energy from the cardiac motion by using a nanogenerator. They call this device a self-powered intracardiac pacemaker, or in short, SICP, that consists of energy harvesting unit, EHU, power management unit, PMU, and also a pacemaker module, PM. However, here, let us focus on the energy harvesting unit and the concept behind it. So, the energy harvesting unit, EHU, consists of polyformaldehyde, POM pellets, and also polytetrafluoroethylene, PTFE film, gold deposited electrodes. So the process on how this works is you can see in the bottom right diagram here is when the heart beats, the POM pellets move back and forth between the two electrodes, as you can see over here. And next, when the POE pellet moving, it will also induce charges on the PTFE film surface, and the charges are what gonna produce the current in the loops. And this process will always keep repeating due to the fact that the heart is always beating. And this current, this electricity will soon be supplied to the PMU and also the PM. So that's the mechanics on how the beating of the heart can be utilized in order to generate electricity for the pacemaker.
To summarize, dual-chamber pacemakers play a crucial role in the management of third-degree AV block by restoring atrioventricular synchrony. By pacing both the atria and ventricles in a coordinated sequence, these devices are able to closely mimic the heart's natural conduction system. Correct anatomical placement of the pacing leads and appropriate timing of electrical impulses allow for improved ventricular filling and cardiac output, which significantly enhance hemodynamic performance and overall patient quality of life. So, what are the future perspectives? Looking ahead, advances in leadless pacemaker technology aim to reduce complications commonly associated with traditional lead-based systems, such as infection and lead failure. Innovations in device design, materials, and energy harvesting technologies are expected to improve device durability and safety. So I think continued integration of anatomy, physiology, and biomedical engineering will be essential in the development of next generation cardiac pacing systems that are more efficient, reliable, and patient centered. Thank you.